All right. Good afternoon, everyone, and welcome to our multimodality imaging conference. Today, we're going to be discussing evaluation of the left atrial appendage from the multimodality standpoint. So I'll be discussing the echo evaluation. Dr. Rameez will be discussing CT evaluation, and Dr. Sherman will be discussing ICE evaluation. Giving you a chance to submit your feedback and your attendance. All right. So we're going to review the different left atrial appendage morphologies, highlight the role of TE in determining the candidacy for and guiding left atrial appendage occlusion, and emphasize the role of follow-up imaging by TE. And these are the different left atrial appendage morphologies. You have the windsock, the chicken wing, cactus, and the cauliflower. Very fitting talk for lunchtime. And it's important to evaluate these morphologies carefully because they could have implications. And you would have to use multiple angles by TEE and sometimes use 3D imaging or biplane imaging to be able to unmask these different lobes. And this figure kind of goes over these different morphologies. So the windsock is this one right here. This is a 3D image of the windsock, and the prevalence is about 19%. It has a long dominant lobe and may have secondary or tertiary lobes arising from that primary lobe. The chicken wing is the most prevalent. The prevalence is about 48%, and it has a central lobe with a bend in the proximal or mid aspect of the appendage and may also have secondary lobes. And this morphology has higher flow velocities as compared to the cactus and the cauliflower types. So your chicken wing morphology is the most common type. The cauliflower or the broccoli is the least common with a prevalence of about 3%. It has an irregularly shaped ostium and complex internal characteristics with varying number of lobes. And this one has the highest risk of thromboembolism independent of the CHATS2 VASC score. So the cauliflower or broccoli, the healthy one, is the least prevalent, but the most morphology that's associated with the risk of thromboembolism. The cactus is the second most common with a prevalence of 30%, and it has a dominant central lobe with secondary lobe extending from the main body in the superior and inferior directions. And the left atrial appendage is the site of thrombi formation in 91% of cases of patients with AFib. So most atrial thrombi occur in the left atrial appendage, and that's in about 91% of patients with thrombi. And it's important to determine when you're evaluating the appendage if you're dealing with spontaneous echo contrast versus clots. We get these referrals quite often to the TE lab to determine if the patient is safe to undergo ablation or cardioversion. And we're sometimes encountered with spontaneous echo contrast, and sometimes it's unclear what we're dealing with. So to go over the different types of spontaneous echo contrast, this table kind of shows the different grades of spontaneous echo contrast, with 0 meaning absence of any echogenicity in your appendage. And then it goes from 1+ to 4+, and finally ends with sludge, which is severe spontaneous echo contrast. And the way you describe it is based on the amount of echogenicity, the distribution, and the movement of the swirling pattern. So when you have sludge, which is severe spontaneous echo contrast, this is a pre-thrombotic state where the spontaneous echo contrast is very pronounced without becoming a thrombus, and it's often described as a gelatinous echo density forming a meniscus level. That's when you call it sludge or severe spontaneous echo contrast. And then if you can notice, there's a variation from 1+ to 4+, depending on the intensity, the velocity of the swirling, and the location within the left atrial appendage cavity. And sometimes when it's not clear if you're dealing with a thrombus or spontaneous echo contrast, then using echo contrast is actually helpful to help you delineate the presence of a thrombus. And this is an example of a thrombus here at the tip of this windsock appendage. And if you see here, when you add contrast agents, there's a filling defect confirming the diagnosis of a left atrial appendage clot. And a point to remember and to emphasize is once you're imaging the appendage, you want to make sure you're able to see the tip. So you want to make sure that you get the length of the appendage in view, use multiplane, biplane. 3D imaging can sometimes be helpful, but make sure you interrogate your appendage in multiple different angles to be able to see the tip and the different lobes of the appendage to be able to detect any thrombi. This second case is a case of spontaneous echo contrast or just smoke. When you add your contrast, you don't see any filling defects, so there's no evidence of any thrombosis, and you can safely proceed with cardioversion. This was a research paper published in JACC Electrophysiology a couple of years ago, showing the effect of using inotropic agents to clear spontaneous echo contrast from the left atrial appendage. And what they used is isoproterenol or dobutamine, titrated every 3 minutes based on the resolution of the smoke, and then those infusions lasted up to 12 minutes. And if the spontaneous echo contrast or sludge cleared, then left atrial appendage occlusion was performed. So again, this is a unique way to differentiate if you have a clot, sludge, or spontaneous echo contrast. First example here, inotropic infusion, you see this echo density, which completely clears with isoproterenol. So this was just spontaneous echo contrast that cleared. By contrast, you see this pronounced echo density right here, and with infusion, you continue to see this kind of meniscus level echo density. This was diagnosed as a clot, and the patients did not undergo left atrial appendage occlusion. So inotropic agents can be used to make that differentiation, maybe not in your outpatient labs, maybe sometimes in the cath lab pre-procedurally. And in the indications for left atrial appendage occlusion, in the ACC-HRS guidelines, you would consider left atrial appendage occlusion in patients with AFib at increased risk of stroke who have contraindications to long-term anticoagulations. And with the European guidelines, again, it's considered for stroke prevention in patients with AFib and contraindications for long-term anticoagulant treatment, such as intracranial bleeding without a reversible cause. And these are some of the common left atrial appendage occlusion devices. So they're divided into endocardial approach versus epicardial and endocardial approach. For the endocardial approaches, these are deployed via the transeptal approach, and those include the Watchman devices and the Amulet device. The lariat device is performed by placing endocardial and epicardial wires with a magnetic link, followed by epicardial sutural ligation of the left atrial appendage. So this has a different kind of deployment technique. And these are the devices that are currently FDA approved. So the Watchman 2.5, the Watchman Flex, the Watchman Flex Pro, and the Amulet devices. Those are the ones that we commonly encounter in our practice. And there are multiple investigational devices that are also currently being studied for the purpose of the left atrial appendage occlusion. We're going to focus on the Watchman Flex and the Amulet devices, and these are the ones that are commonly used. So baseline imaging before these procedures, you want to confirm that the appendage is free of any clots. So this is your first step. Make sure that there's no clot in the appendage, and we talked about visualizing the appendage in different angles. You can use X-plane and 3D imaging, contrast if you're concerned, whether you're dealing with spontaneous echo contrast or clots. And you also want to make sure that you identify the artifacts. If you have an artifact from the comedon ridge, this will disappear when you use different planes. And also make sure that you're identifying the pectinate muscles, which can be contracting with the cardiac cycles. You want to evaluate your atrial septum for any aneurysms or shunts, evaluate for any mobile aortic plaques, presence of baseline pericardial effusions, and the presence of any intracardiac clots, which would be a contraindication to these procedures. Left atrial appendage sizing is done by mid-esophageal views of the TEE, because that's where you visualize the left atrial appendage landing zone and gives you the maximal dimensions. Rotation and manipulation of the probe should be performed at every angle to ensure visualization of all the different lobes. And oftentimes, in one angle, you're able to see one lobe, and then once you start increasing the angle or changing the angle, you start seeing extra or additional lobes. So you want to make sure you're looking at the appendage at 0, 45, 90, and 135. You can go to these different angles separately or use X-plane imaging or biplane imaging. You could consider IV fluid bolus or optimizing the fluid status before measuring the left atrial appendage dimensions. Again, this was a study published a few years ago demonstrating that when patients come into the procedure, they're NPO, they're under anesthesia, and sometimes those dimensions can be underestimated. So what they did is they gave a bolus of about 500 to 1 liter of normal saline, and they did the measurements shortly thereafter. And that seemed to increase the size of the left atrial appendage by 10%, which when you're trying to size a device could be significant. Accurate sizing is crucial because if you're undersizing the device, this could lead to device embolization. And if you're oversizing the device, that can lead to left atrial appendage rupture. So accurate sizing, which is done by TE or, as Dr. Rameez is going to discuss, by CT, is very important. And one of the reasons sometimes we see greater dimensions with CT could be related to this fluid status situation, which we encounter in patients with TE who are NPO and under general anesthesia. For the Watchman device, you again want to perform these measurements at those different angles, and your landing zone is defined as the distance between the left circ to a point 2 centimeters below the tip of the left upper pulmonary vein limbus, or the comedal ridge. And the depth is defined as the distance between the landing zone, which is that yellow line, to the most distal tip of the appendage. So those are the two measurements that you would need for the Watchman device at each different angle. And 3D imaging can be very helpful also to get this en-face view of the landing zone, and you can get your minor and major dimensions using 3D imaging. This is just a chart demonstrating the device size selection for the Watchman device, the Watchman Flex. And again, it depends on your landing zone diameter. So your landing zone diameter will dictate the type of device that's used. And it's important to mention that when you get this measurement in different angles, the number that you go with is the maximum diameter you're able to get. So if your diameter measured largest at the 135-degree angle, then that's the number that you would use to size the device. So you go with the maximal dimension you're able to get using the different angles. And once once the device is deployed, and we'll talk about this a little bit more, then you want the device to be compressed. And the compression diameter is this one right here, which is measured at the shoulder of the device when that threaded insert is clearly visualized. So you want to see about 10 to 30% compression of the device in the left atrial appendage to make sure it's stable in place. The Amulet device can have different measurements compared to the Watchman device. The landing zone is measured 10 to 12 millimeters from the ostium, and the depth is measured in a line that's perpendicular to this landing zone from the ostium. So this is your ostium. Your landing zone is 10 to 12 millimeters below the ostium, and your depth is measured from the ostium in a perpendicular line to the ostium, rather than to the most distal tip as compared to the Watchman device. The procedural steps include transeptal puncture, advancements of your delivery catheter, contrast angiography through a pigtail catheter into the appendage, device deployment, release, and then screening for any complications. And it's important to be familiar with TE and fluoroscopy views. For example, this is your RAO caudal view, which corresponds to the 135 degrees on TE and shows the major axis of the left atrial appendage orifice. By contrast, this is the RAO cranial, which corresponds to your 45 degrees on TE and shows the minor axis of the left atrial appendage orifice. So you want to be familiar with both the fluoroscopic view and the TE views. Transeptal puncture is usually done inferiorly and posteriorly in the fossa ovalis. So you want to be away from the aortic valve and closer to the IVC than the SVC. And these are some 3D imaging demonstrating that transeptal puncture and then the course of the catheters as they traverse the left atrium into the left atrial appendage right here. So a combination of 2D imaging and 3D imaging can be helpful as you're guiding these procedures. And this is a case. This is the initial contrast angiography. You can see the appendage. You appreciate the size, the shape, and the number of lobes. This is TE, where the guide catheter is at the ostium of the left atrial appendage. This is the device positioning by fluoroscopy. This is the device deployment by TEE. And finally, the contrast angiography after the device is released. So a combination of fluoroscopy, TE, or ICE imaging, as Dr. Sherman will shortly discuss. 3D imaging kind of showing the same thing. This is your left atrial appendage. This is your aortic valve. Then this is the device deployment. The bubbles here you see are the contrast angiography that they perform. And then this is the occluded appendage with that Watchman device after the device is released. Before you release the Watchman device, the pass criteria have to be met. So once you position the device in the left atrial appendage, then you have to check for 4 different things. P stands for position, so you want to make sure it's properly positioned with no tilt, so it's not tilted and it's coaxial. You want to make sure it's anchored well, so what we do is we perform a tuck test where you pull and push on the catheter and make sure that the device is stable and doesn't move. You want to check the size, which is the compression that I talked about. So you want to measure that shoulder to shoulder where you see that threaded insert and make sure you have adequate compression of about 10 to 30%. And finally, check for the seal, which is screening for any peri-device leak by using color Doppler. Once the pass criteria is met, only then will you be able to release the device. And the device should be deployed parallel to the left atrial ostium. So this is an example of optimal deployment. It's parallel to the ostium. Shoulder protrusion of the device should be less than 40 to 50% of the device height. And excessive tilting can lead to excessive shoulder protrusion. And this is an example of it. You have that shoulder that's protruding. There's tilting of the device. And you can appreciate that by 2D. I think I have a more zoomed in view. This is the shoulder protruding, and the device is tilted. And you can see that by 3D imaging as well. All that is the protruded shoulder compared to this well-seated device right here, where you don't see that shoulder. Peri-device leak assessment is also performed at multiple angles, and you want to change your aliasing velocity between 20 and 30 centimeters per second. You interrogate it at different angles, and you measure the largest diameter that you're able to see. A relevant peri-device leak is defined by the presence of colored Doppler jet that's more than 5 millimeters for the Watchman device. And if it's a significant peri-device leak is detected, then the device needs to be repositioned or replaced with a different size. Again, that's part of your pass criteria. You finally check for a leak, and don't forget to change your aliasing velocity to 20 to 30. These are 3D images and 2D images of a peri-device leak that you can see right here. You can see it by 2D imaging, and 3D imaging also helps us size it and confirm the presence of color. The Amulet device deployment is a little bit different. It starts with deploying the Amulet ball in the left atrial appendage, followed by the lobe. And then once the lobe is deployed, then you unsheath that disc. And that would be your left atrial side of the Amulet device. So it has the lobe and the disc. And you start by deploying the lobe, followed by deployment of the disc. A peri-device leak less than 3 millimeters on the Amulet devices is acceptable. Similar to the pass criteria, the Amulet has the close criteria. That's what you want to check for before you release the device. So you want to make sure that 2/3 of the device lobe is distal to the circ. The device lobe needs to be compressed. Orientation should be coaxial to the left atrial appendage. Similar to the Watchman, you do a tuck test, so that ensures the separation of the disc and the lobe. And finally, the disc has to have an elliptical or a concave shape. So these are the close criteria for the Amulet device. Some of the procedural complications that you may encounter include a pericardial effusion. You want to pay special attention to the RV-RA junction. Use transgastric imaging to screen for pericardial effusions, and you want to evaluate for an effusion in the setting of hemodynamic instability. So if you're doing a case and the blood pressure drops, during such procedures, you want to pause and you want to look at different views and rule out the presence of any pericardial effusions. Vascular injury, you want to look for wall motion abnormalities due to proximity to the circ. Interference with the mitral valve function, you want to evaluate your mitral valve leaflets before and after deployment. And device embolization, which is pretty rare. That's why it's really important to size those devices accurately. Iatrogenic ASDs can occur as a result of these procedures with transseptal puncture. You want to assess the directionality of the shunt. If you're dealing with a left to right shunt, then you don't really have to worry about this shunt. But if you're dealing with a large defect, or if you have bidirectional shunting in the setting of severe TR or pulmonary hypertension, you might want to consider ASD closure in these cases. So that's why evaluation of TR and PA pressures are important parts of the baseline evaluation. And this is an example of the ASD by 3D imaging, helps us size the closure device. Follow-up imaging is performed 45 days after the initial implant, and those are the cases that come back to your outpatient TE lab. You want to assess the device stability, presence of any peri-device leaks, the presence of device-related thrombus, which is usually on the atrial side. This one, that's more concerning. A thrombus on the excluded side of the appendage is not concerning. And if your device is stable in position with no evidence of peri-device leak or device-related thrombi, then in cases of Fodgman device, you can stop the anticoagulation and start dual antiplatelets. Patients with the Amulet device are on dual antiplatelet therapy. And these are examples of device-related thrombi. This is by 2D TE and 3D TE and CT, which Dr. Rameez will discuss further. And they have different morphologies. This is actually a very nice review that was just published in JACC EP, showing discussing left atrial appendage occlusion, has very nice images and figures, and shows different morphologies of device-related thrombi. In the Amulet devices, they tend to be sheet-like, versus in Watchman cases, they're more dramatic, pedunculated and mobile. And this is an intra-op picture of a thrombus. So these complications, although are uncommon, need to be understood. So device embolization, we talked about the importance of accurately sizing these devices. If you're undersizing the device, that's a risk of device embolization, but the incidence is pretty low, 0.07% in the NCD-LAA registry, and in the different studies, pretty low. For device-related thrombi, it's about 2 to 4%, and the reason for these thrombi could be patient-related factors, or procedure factors, or post-procedural antithrombotic regimen. So different factors can contribute or lead to device-related thrombi. And finally, if you do encounter a significant peri-device leak, which we've discussed earlier, then these are the possible management strategies for these PDLs. So if you're dealing with a narrow one, 1 to 3 millimeters that has a narrow landing zone, then radiofrequency ablation is an option, or using detachable embolization coils. And if you're dealing with a larger one with a wide neck, more than 3 millimeters, then you could use embolization coils, vascular plugs, or cardioform septal occluders, or radiofrequency ablation. So if you're dealing with these significant PDLs, then there are treatment options based on the size and the availability and the expertise in the center. And I want to highlight the role of 3D printing for device selections. There have been multiple publications using TE and CT-based imaging to create these 3D printed models, especially for complex anatomies, to help us determine the catheter trajectory, the curvature, and the size in complex cases. Obviously, you're not going to do this for every single case, but in complex anatomies, then 3D printing can be helpful, and nowadays computational modeling can also be helpful in sizing these devices. TE and ICE are both used to guide left atrial appendage occlusion, and Dr. Sherman's here. We're very happy to welcome him to our multimodality imaging conference. We've embraced ICE as as an imaging modality that belongs with the other imaging modalities, and we have greater appreciation for its role in left atrial appendage occlusion, in tricuspid interventions, and we thought this would be a good platform for us to get to know more about the different views and the utility of ICE for such procedures. For left atrial appendage occlusion, then TEE offers high resolution imaging. It's familiar to cardiologists and anesthesiologists and has 3D capabilities, which actually now applies to some of the ICE catheters. ICE is familiar to most electrophysiologists, reduces the need for general anesthesia, and results in shorter in-room time and faster turnaround time. Disadvantages of TE, well, it's operator dependent. That's not an issue in our center. Requires additional operator for imaging, requires general anesthesia, and the inherent risks of doing a TE exam. The disadvantages of ICE is you have limited imaging angles, requires transseptal dilation or a second transseptal site to get your catheter into the left atrium. There's a learning curve like anything new that we introduce. And 4D ICE catheters have increased procedural cost and is not currently widely available. I'll end with that and just say TE plays an instrumental role in planning of left atrial appendage occlusion, in addition to procedural guidance, detection of complications, and procedural follow-up. Turn it over to Dr. Rameez, who will discuss CT imaging of the appendage.
Thanks, Dr. Faza, for that amazing talk, looking at the role of TEE in evaluating the left atrial appendage. And this talk is going to be complementary, just highlighting all the modalities we have available and the complementary role of TEE, CT, and ICE imaging in this space. I have no disclosures. My objectives are quite brief, but this is quite a broad topic. Looking at the role of CT in the evaluation of left atrial appendage by thrombi, and then its role in the pre- and post-procedural space. And then if we have time, we'll also look at some cool intraprocedural CT images. All right, so let's kind of first pause and talk about what makes it different. What is a CT protocol for left atrial appendage, and how is it different from a CT done for example, coronary assessment, and what the guidelines suggest. So this is different centers will, based on what scanners they have, the expertise they have, scan the patients differently with the initial scan. So, you know, the guidelines will recommend ideally that the scan is prospective, it's gated, that it's focused in end systole, which would be like that 30 to 60% of the RR interval. You want to use similar contrast as you would for a coronary CTA. So we are aiming for ideally 450 HU in the left atrium. Your heart rates can be quite liberal. So, you know, unlike the coronary CTAs, because the coronaries are quite narrow, we don't need to have a very tight heart rate target. So it's very suitable for our patients with left atrial, with atrial fibrillation, because the left atrial appendage is quite large, and we usually can evaluate it. And really the crux of the scan and what makes it really different is the delayed scan. So this is a scan that this is a second acquisition, 30 to 180 seconds after the initial scan. So we would time it at the peak of the contrast injection for the initial scan. The guidelines recommend ideally this should be 60 seconds after the initial, but anywhere from 30 to 180% seconds after is acceptable. Important to know, some centers will do retrospective imaging in the initial space. Others are doing prospective. We do flash systolic imaging. If we're doing dose modulation, keep in mind the BMI, and you could do dose modulation. For example, if you're doing a retrospective analysis, you know, have the highest radiation at the end systolic phase and then decrease the radiation, but don't do that in the post-procedural space, because you really want to be able to penetrate the device, the fabric, the struts, and get a good assessment of the device and the left atrial appendage. So this is an example that highlights the importance of the delayed imaging. So the first set of images, we have what we're calling slow filling. So there's a defect in the left atrial appendage, a filling defect, and that is cleared on the delayed imaging. So that is consistent with slow filling and consistent with kind of smoke on TEE. On the second set of images, we have a defect, a filling defect in the initial scan that then persists on delayed imaging, and that is consistent with thrombus. So this is where the delayed scan really helps in improving the specificity. And so this was a meta-analysis done in 2012, which showed that the specificity, the negative predictive value, the sensitivity was across the board quite variable across the studies when we looked at the CT's use in the evaluation of left atrial appendage for thrombi. However, when we added the delayed scan, sensitivity across the board was 100%, specificity was 98 to 100%, as was the negative predictive value. So it's really important to add that delayed scan. I think that's the really important point when we talk about using CT in this space. Some of the advantages and limitations, where we talked about some of the issues with TEE, where patients are fasting and maybe require additional bolus of IV fluid. So patients who are coming in for CT, they do not require fasting or sedation, and really allows us to image the left atrial appendage in its max size. It's quick, it's non-invasive. It allows us to have high-resolution images with most of our modern CT scans. Allows for image reconstruction using kind of 3D modeling software after the patient leaves. Also can allow us to calculate the procedural angle similar to TEE and look at the interatrial septum for accurate transeptal puncture location. And then we can look at the surrounding anatomy. Of course, some of the limitations are that we are giving contrast, and you would want to avoid giving contrast in patients with a GFR of less than 30. Of course, there is radiation exposure, and we can't detect flow velocities. So we've already talked about the different morphologies of the left atrial appendage, and this is just a CT correlate. As has been mentioned before, the chicken wing is the most common, and the cauliflower is the least common, but the most likely to be associated with thromboembolic events. All right, so looking at the use of CT in the pre-procedural planning space, so you can, of course, exclude thrombi in the left atrial appendage, plan the transeptal puncture, assess the left atrial appendage for appropriate device sizing, look at the surrounding anatomy. We can do 3D printing in complex anatomies, as I mentioned before, and then there's a potential for fusion imaging with fluoroscopy. And so there's various devices available in the market, as Dr. Faza mentioned. I'm going to focus on the Watchman device to keep it focused for the purposes of time. And so when we get our acquisition, we want to first identify the left atrial appendage. And so we're looking at the axial image and using our crosshairs in the coronal and sagittal planes to locate the left atrial appendage. And there we want to locate the left circumflex artery. We want to position our crosshairs at the base of the left atrial appendage, and then basically find and align the left circumflex artery to the ridge of the left upper pulmonary vein. And so for the Watchman device, similar to TEE, the landing zone is a 0.2 centimeters, 1 to 2 centimeters inside the left atrial appendage, measured from the tip of the left upper pulmonary vein ridge, at a line connecting the left circumflex artery and the left upper pulmonary vein ridge. And then the depth or the length would be a line connecting the landing zone to the tip of the appendage. And so that would be, so you would want to use the widest diameter to size your device, and then the length needs to be at least 10 millimeters to use Watchman. And so this is kind of the sizing chart for Watchman and Watchman Flex. Again, we would use the maximum length, not minimum, and then the device size needs to be 3 millimeters larger than the max diameter. Device length is affected by compression. We would look for that 10 to 30% compression. So this slide highlights the how CT can be helpful in understanding the surrounding anatomy. So the first image shows a graft to the obtuse marginal branch, a venous graft, and how closely it is courses to the left atrial appendage. The second one just highlights the relationship of the left circumflex artery and the great cardiac vein to the left atrial appendage. Here we see a sinoatrial nodal artery branch of the left circumflex artery as it courses close to the left atrial appendage. And this artery actually has quite a lot of anatomical variations, and so it's important to kind of note it when we're reading these CTs. Lastly, we see a persistent left SVC and how it courses between the left atrial appendage and the superior pulmonary vein. And so moving on to CT in the post-procedural follow-up space, it can identify device position. We can look for left atrial appendage patency, see if the device is healed, if there's any device-related thrombi, if there's any leak, and also look for rare device complications. So this is a case that highlights successful occlusion of the left atrial appendage. We see that the left atrial appendage there's no contrast. The contrast HU is less than 100. We see that the device is appropriately positioned, and there's no apparent peri-device leak or device-related thrombus. Contrast this with this patient, where there is clearly a significant peri-device leak. We measured it at 7 millimeters. And then there's contrast in the left atrial appendage. And then when we look at the Hounsfield units, it's greater than 100, so about 300. And when you compare the HU in the left atrial appendage with that of the left atrium, you see that the ratio is about 0.7. So that's kind of another indicator of patent left atrial appendage. So either the presence of contrast with HU greater than 100, or the ratio of contrast in the left atrial appendage to that in the left atrium of greater than 0.25. So when we're assessing peri-device leaks, we want to give the cross-sectional area diameters, and we want to get that at various positions, proximal lobes, middle lobes, to help the operator think about what to do post-procedurally, how to plug these leaks. CT does report larger peri-device leaks than TE, so that's something to bear in mind. I think it has to do with better resolution. So if you have clear peri-device leak and the left atrial appendage is patent, you want to identify the size of the leak. So as has been mentioned for the Watchman, anything above 5 millimeters is considered significance, and then you would kind of continue oral anticoagulation and consider further interventions. Now, if you have patency of the left atrial appendage, but there's no significant peri-device leak that is noted, that is kind of attributed to incomplete endothelialization. And at this point, we don't really know what to do with that. And so a conservative approach is recommended. We talked about significant leaks being greater than 5 millimeters. It's important to note that actually smaller leaks are associated with a moderate increase in thromboembolic events. And that is associated with the de-escalation of oral and anticoagulation therapy. So larger leaks, patients are likely to get definitive therapies, or they're going to be on oral anticoagulation. So even if a peri-device leak is insignificant, we shouldn't really discount it as being completely protective of thromboembolic risk. Okay, so CT can also help with assessment of device position. So if you have uncovered lobes, if you have a proximal device position, so excessive device protrusion of greater than 30% for the Watchman is associated with instability. Malposition of the device, so similar to TEE, you want the device to be coaxial to the main left atrial appendage lobe, and if you have off-axis implants, those are associated with peri-device leaks. Deeper implants, so greater than 10 millimeters, as measured from the tip of the left upper pulmonary vein ridge, are associated with increased risk of device-related thrombi. CT can be very helpful in assessment of post-device hypoattenuation, thickening, and device-related thrombi. So the overall incidence, as has been mentioned, is 2 to 5%. CT is more sensitive, and the identification of device-related thrombi on the atrial side of the device is based on the presence of hypoattenuation. So if we just see hypoattenuation that is located just around the screw hub cove, that's thought to be more subfabric, so that's actually not true device-related thrombus. Similarly, if you have hypoattenuation on the atrial side of the device, but the thickness is less than 3 millimeters, or if it's greater than 3 millimeters, but it's smooth and in continuation with the left atrium, that's considered grade 1 hat. So grade 0 and grade 1 hat are considered to be precursors to device endothelialization, and they're not associated with increased embolic events, and we would treat them conservatively. Now, when we go on to hypoattenuation that's seen with a greater than 3 millimeter thickness, but is not continuous with the left atrial wall, or if you have irregularity on the surface like this, or if you have significant pedunculation. Now, these are significant device-related thrombi and then should be treated with continuation of anticoagulation. So this just kind of details what to do when you find grade 0 or 1 hat, which would be conservative management, and 2 or 3, which would be considered device-related thrombus. Some of the risk factors for device-related thrombi are age, female gender, history of stroke, high CHA/DS, non-paroxysmal AFib, CKD, and presence of slow flow on echo or reduced EF, deeper device implants. And so certain centers will do follow-up imaging after they've de-escalated anticoagulation in patients who have higher risk factors for DRT. So as has been mentioned, device embolization is a rare phenomena, thankfully, but it does happen. And so this is a case of a patient who had successful implant of a Watchman device, had de-escalation of anticoagulation, came back about a year later with a stroke, and was found to have device embolization, which was lodged in the descending aorta. So the descending aorta is the most common place where it embolizes, and then the left atrium followed by the left ventricle. So we talked about pre- and post-procedural CTs, and Dr. Ron Jacob at York Hospital was very kind enough to share their experience with intraprocedural CT. So they have a limited, kind of 8-centimeter limited Z-axis coverage intraprocedural CT, which just focuses on the left atrial appendage. They do a retrospective full cardiac cycle acquisition. They inject contrast through the femoral sheath and start imaging 5 seconds after the contrast is injected. And so these are kind of their intraprocedural TEE and CT images. And as you can see, it gives a really good kind of assessment of the device as the patient is getting the procedure. It's also really helpful when you get follow-up imaging. So this was a patient where there was prominent hypoattenuation versus soft tissue overhang, and they were able to compare it to the intraprocedural CT and say, actually, this is prominent soft tissue overhang, and we're able to resolve this issue. So as we're getting more and more CTs post-posteriorly, this could be something that a center could incorporate into their protocol. Okay, so these are kind of my take-home points. CT can be very helpful in the pre-procedural space, the post-procedural follow-up, and then also in the intraprocedural space. Really the importance of that delayed acquisition. Different centers will do it differently, but the importance of delayed imaging needs to be underscored. It's non-invasive, rapid, provides high-resolution images, but obviously we're giving contrast, there's radiation. For the Watchman, you need to identify and measure the landing zone, the length of the appendage. Left atrial appendage patency is defined by an HU of greater than 100 or a ratio of contrast in the left atrial appendage to that in the LAA of greater than 0.25. If you have a PDL, if you don't have a PDL but the left atrial appendage is patent, it's uncertain and conservatively managed. And high-grade HAT and DRT warrant anticoagulation. Thickness of greater than 3 millimeters, pedunculation and surface irregularity are some of their features. And then some of the risk factors for DRT. Thank you.
I think it's my turn now. So I'll be talking about eyes and left atrial appendage. And of course, this is the one with the least resolution of all 3 modalities that we have talked about. Yeah. and we're gonna have a blast. So we have been working in have no disclosure since imaging on Watchman since back in 2018. We make a comparison between the left atrial closure device using eyes versus TEE, the pros and cons, as cost, as and timing, and we have some data that we published back then. Then back in 21, we did a complete review of the imaging and more how to try to duplicate the TE images based on the angles and the maneuvers that we have to do in order to duplicate that. And this is exactly how we were trying to duplicate. And you can see you have a better resolution on the TE and you have a worse resolution with the eyes. However, you do have a closer proximity with the left atrial appendage. However, I do think that we're getting better at this and we're evolving in imaging the left atrium with the eyes, okay? And if you look at the left atrial appendage in this matter and you know the anatomy, you may understand the views better, okay? So the eyes' difference is that you are at the appendage. You are really in the appendage when you're looking at it. So you can look it from the roof or from the bottom, that will be a 90-degree. Or if you're looking from the pulmonary vein or the mitral isthmus, that will be almost a 0-degree. These angles are not interchangeable with the TE. These are the angles based on the appendage, okay? And then you have a 45-degree if you look the left upper crossing to the aorta, and I'm gonna show you that. But first of all, let's start with clots. Can we see clots? Yes. This is a view from the PA. I'm gonna show you really quick. So as you can see right here, there's we believe it is a clot. The TE was inconclusive, so we went in and we went into the PA, and we were saying this is obviously a clot formation. You're taking a look from the pulmonary vein, and these are two still pictures that you can see from the pulmonary vein that you can see the tip and the body with clot. So yes, you can obviously see. Obviously, you want to detect it before you get to there. But sometimes we don't. Sometimes we're there and we check with this way, okay? So this is a color. You can see we were doing color flow there, and there's no, sorry I didn't put you the velocities there, but there's nothing goes in there. DAT, we can also sue device-associated thrombosis, devices-associated thrombosis. Here's a quick zoom at it. As you can see at the surface of the Watchman, there's a clot looking at it. So yes, we don't have a good resolution, but if we get close to it, we might be able to visualize it. So let's talk about the basics views, okay? You can get views from the right atrium, you can get views from the left atrium. You get views from the right atrium. The first view that we get is the RVOT. The RVOT is a great view to see the Coumadin ridge and the ostium of it. You can get a good measurement. The problem with the view is that you are subject to the aortic valve. And we have interventional cardiologists who like to replace it transcutaneously, and then once they do that, this view is no use because it's a lot of shadowing. So then you have to advance more past the aortic valve, get into the PA, and then you're gonna be able to visualize the left atrial appendage, which is great for the tip, but you don't see the body very well. You need to have an idea of how many tips the appendage has with CT. That's the best resolution in that part. This is the example of one of the clot scenes by the PA. This is another view. There's no clot, and you can see right there the tip of the appendage very well visualized from the PA. So the PA artery is very close to the tip of the appendage. And believe it or not, the CT scan is a great tool for that. And we're actually looking forward for our CT imagers to show us and tell us about which part is too close to the PA artery. Because most of the time when we perforate and there's a massive hemorrhagic, it's usually because the left atrial appendage is too close to the PA artery, especially the ostium where the anchor's landing. If you put the Watchman device and it's a thin wall, like for example, I think in number 2, you can see that it's pretty close. I gotta wrap it up because we're close and I'm gonna finish on time. So here's more views about the PA, guys. So here we can see that tip. We can put colors also to make sure there's completely flow on that. We can see other lobes too, so it's good for that. But there's another, it's pretty bad when the Watchman is already deployed because you're seeing the tip of the appendage. So nobody's interested in the back, on the other side of the appendage. Everybody's interested on the front side of the appendage. So the PA view is not very helpful once the Watchman is deployed, okay? And now let's talk about left atrium. So you gotta go transeptal. It's very important to have visualization, and I'm gonna, as my TE major, look at how these transeptal needles can move. So that's why we get very paranoid when we're going transeptal and ask, please get us the tip, because sometimes it can move and with breathing or something like that. And it depends on patient to patient. Some patients are very stable, the tip, and the transeptal is very good, but sometimes it's not. And you can see this is a small fossa and it's moving in and out of it, so we have to time it pretty good. So these are the basic view. We can get one from the mid left atrium, we can get one from the pulmonary view, one from the aortic, one from the mitrals, and a 90 degrees. If we get into the pulmonary vein, it will look like this. I put the marker here as your TE, your eyes probe here, and it's looking all the way down. So you will see some mitral isthmus, you will cut the appendage, and you will see the ridge, okay? There's an example of the view and how we're looking at it, right? So you see the mitral, you see you cut the circumflex, and then you have the pulmonary vein, and then you have the Coumadin ridge, and you're in the pulmonary vein. So how do we get there? So we're in the mid atrium, we find the ostium, and we navigate, we dive into the pulmonary vein, and we get in there. Once we're there, we can start doing measurement. It's very good for the ostium, not so great for the tip. Here you can see there's pectinate, so you really don't know it's a clot or not. That's why we went to the PA view, which give us a good insight about the distal part. This is more ideal for the body and where you're gonna land with the Watchman device, okay? We can do our measurements and confirm the TE measurement from prior or the CT measurement prior, we double check, okay? And we can also measure the LA pressure because it's important. When you're hypovolemic, your appendage may be looking smaller, so it's important to know the right of that. Then this is more of the same. I'm gonna skip it. This is our measurement after deployment. You can see we're measuring the compression. We can also put colors. Then this is the other view, okay? This is when we put it, we call this the aortic view. You have a short axis of the aorta, and you're cutting it basically from here to here. So here's our Coumadin ridge. This is the inferior. This is the appendage. This is our anterior lobe, and this is the aortic valve. So we have another transection. We do our measurements over there, and that's great. Okay, so here's some examples of that view that we have right there. This is called the aortic view. It's quite straightforward to get it. The next one is the mitral isthmus view. This is great to looking for the shoulder of the Watchman in the mitral area. Okay, so once that we deploy, we put the eyes on the other side, in the ventricle side, and we start looking, there's more ventricular. So this will tell us how much exposed do you have there, okay, on the mitral. And then we have the mid atrium. The mid atrium, we put the probe around here, and then you can counter and clockwise, so you can see pretty close the appendage directly, looking at it directly. Like in this case, you counter and clock, and then you start to looking for any gaps or seals, okay? However, all these views are really good, and actually the one that looks the best usually is the very first one that I show you inside the pulmonary vein. All Watchmen look fantastic over there, but that's not the storyteller. The storyteller is this guy, the one who shows you the floor of the Watchman, which is this view right here. This is, to me, if I have to choose one view, I agree that one view is not good as no view, but if I have to choose this view, is the one that has the most shoulder is this one, because usually it's the floor of the appendage that has a hole because the mitral valve is in there. The roof, you always have a roof. The Coumadin ridge extends pretty deep in, and the septal part is very good anchor there to the mitral, but the floor right here that I show you here is where usually the shoulders are. This is one view, and you can see we're right there because in this view, we're not seeing any veins, we're not seeing any mitral isthmus, so we're cutting it from the roof to the bottom, okay? You see a little bit of mitral isthmus, but your patient is moving and the heart is beating, but the idea is to have that cut. And if you don't have no shoulder in this view, that's a good implant, okay? Of course, we do talk tests. I always advise, maybe take this in consideration, that when you're doing talk tests, ask them to go faster than the heartbeat. How do you know that the talk test was not the heartbeat? The only way to know is moving faster. So if you look at this image, you know, at the end, you don't know if it's the talk or not, but at the end, that's a talk, okay? You can see that we move faster than the heartbeat, so you know that's the movement of your operator doing the talk, and you can see if it's moved with the appendage or not. But if you move it at the same speed of the heart, then you really don't know, okay? Okay, colors, it's important to use colors, always. This is a mitral isthmus view, so you can see we have the mitral apparatus, no shoulders, no leak. And we can do the measurements also. And I'm gonna wrap it up because we're almost out of time. The last thing we see, we can check also the work of our interventionals. I'm gonna show you the left main here. They left a stent outside poking, look at that. That's a stent poking out of the left main from our great interventional. So here's a patient with CABG. So you can see the left main very well from the left atrium. I just wanna share this with you. This is our aortic view. When we're already done with the procedure, we're coming out. The TE people have, oh, this is our aortic view, that means we're finishing. When we start looking at the left main, that means that we're on our way out. So you can see here that you can see the narrowing pretty clear, right, of this. This is a patient with bypass, and we were seeing that the left main was significantly diseased. We even do color, and then we put the velocity and all that, something to look into that. Anyway, thank you very much. I finished on time. All right. That was amazing.